and online. It's fixed. Okay.
Okay.
Please proceed.
Sorry about that. And partner engagement, and we want to thank all of our partners that help us with initiatives and the collaboration we receive. And then we have also been better at focusing on public health and Medicaid integration within our own agency, but also with other agencies such as the Department of Agriculture and the Department of KDADS and DCF, which obviously we run Medicaid with them. It's a joint program. So basically, that's kind of in a nutshell where we are. I'd like to now, unless there's questions, turn it over to Deputy Secretary Ashley Goss to talk about public health and some of the other requests that were made by the committee for reports and things. Is that okay?
Thank you.
Thank you.
Good morning, committee, and good morning, Chair. I'm Ashley Goss, Deputy Secretary for Public Health at the Kansas Department of Health and Environment. And I'm assuming you have slides in front of you or electronically, because I'm starting on slide 6, just for reference. Do you have our slides? The committee has them? Okay, so I can go proceed. All right. So one request that the committee had was to find out what reports are required to submit to the legislature on an annual basis. And on page 6, you'll see those. I'm not going to go over them individually, but there is a list of them from both Medicaid and from public health. So if you have any questions about those, we are more than happy to answer them, but these are the only ones that you guys have required of our agency to submit. Next slide. So the Division of Public Health, you'll see our mission to promote and protect health, prevent disease and injury among Kansans. That has remained our mission for as long as public health has been around. Next slide, you'll see a list of all of our bureaus, and I'm going through this kind of quickly. I know for some of you that are new, if you have specific questions, please let me know. We're more than happy to meet with you offline or answer questions during committee. But in the Division of Public Health, you'll see the 8 bureaus that are listed there. Those are all under the division. One of the ones that was added last year was our lab, and I'm sure you guys have all seen the lab. It is in the process of opening now. It's right across the street from Docking Building. So that's just a change. It was effective last year, but you'll see it now again. On the following slides is a little bit of an overview of each of our bureaus. All of our descriptions of our bureaus are online, so you can go on our website and see a deep dive of every single bureau and what is done in that bureau. And again, we're also more than happy to answer questions about that. But just briefly, Bureau of Community Health Systems is where the Kansas Train program lives, which is a training platform across the entire state that other states use as well, where we are able to build courses and host courses for various stakeholders to be able to obtain CEUs or take a learning opportunity, different things. It's not limited to public health. Also, that's where our radiation program lies, which is kind of odd that it's in public health, but that's where it is. So the radiation program is responsible for monitoring our nuclear power plant, Wolf Creek, and participating in activities as required by the Nuclear Regulatory Commission. Bureau of Facilities Licensing, that's the bureau that most in healthcare do not like. It is our survey bureau. We do the work on behalf of CMS, and it is required by CMS. So we go in and we survey, license, evaluate all healthcare facilities with the exception of long-term care. Long-term care is done by KDADS. All right, I'm on slide 9. So any new facility that's opening up or changing their status, we do that licensing and evaluation of. We also work in partnership with the State Fire Marshal as well on licensing and issues there. Okay, keep going. Keep going. One more. All right, Bureau, thank you. Bureau of Epidemiology and Public Health Informatics. That's where vital statistics lies, where all of the vital records are. I'm sure you all are familiar with that. That's also where all of our epidemiology team works out of. They're all stationed within there and across the Bureau, evaluating data. And that's where a lot of the dashboards come from that you see on our website. Bureau of Health Promotion, think not only promotion, but prevention. So suicide prevention, we do work out of there. Diabetes prevention, work out of there. Heart disease, anything you can think of is probably lying in that bureau. It's all inclusive. All right, Bureau of Disease Control and Prevention is exactly what it sounds. This is where our tuberculosis program lies. So that's where our TB state controller is located. That is responsible for stopping the spread of tuberculosis, as well as our STI program. That program is obviously what it says, but we're also responsible for investigating all HIV and syphilis outbreaks and to stop the spread of that, and working with our local partners and other things that are transmittable. In addition to that, that's where our immunization program lives as well. The Vaccine for Children's program is also based out of there. The Bureau of Oral Health is very small. There's about 4 employees, one of which is our state dentist. They work across the state, working with partners to do screenings and education. Next slide. Bureau of Family Health, the easiest way for me to sum this up for you is they do everything from for our women, infants, children from birth to death, essentially. So maternal child health, family planning, our WIC program, a lot of great work comes out of that program. And finally, our lab. As you can see, the lab provides about 1 million clinical environmental tests annually. So it's not just a public health lab, it's also an environmental lab. It does do all the water samples from our public water supply, among other things. And as I mentioned earlier, they are getting ready to open. The staff is currently moving into the facility. We hope to be fully operational and functional 100% out of that lab by June, if not before. We currently are having vendors come and move equipment. It is required that they move it. We can't move it. It all has to be recalibrated. So currently we're working out of 2 different labs. Our BSL-3 lab, which is a lab that tests some of the things that no one wants to talk about, such as anthrax, white powder, things like that, is remaining at Forbes until our generator is here. It's been on back order. It's supposed to arrive next week. And then that lab has to be fully functional and operational, and we have to be able to show that it can operate with the generator as well before it can be credentialed. So we still have it running. It'll just stay at Forbes until it's certified and can move. Next slide. So just a little bit about public health. We are asked to tell you where the state interfaces with local public health. And I'm guessing that Randy from Caldwell will touch on this as well. So like half of all the states in the United States, Kansas is considered a decentralized public health state. And what that means is all health departments act autonomously. So they act under their Board of County Commission and their health board, which is generally the same. They are required to have a health officer. And depending on their population, depends on who the health officer can be. But if they're under 100,000, the health department director can be the health officer regardless of credential, as long as they have a physician working alongside them. If they're over 100,000, they have to have a credentialed medical person as their health officer. So where does KDHE fit in on this? We provide most of the funding. So locals are funded not only with their local budget, which could be made up of however the county commission chooses to do it. Each county commission can fund their local county agencies as they see fit. A lot of them get tax revenue. Some of them get billing revenue, obviously. Just however they see fit is how they're funded locally. The grants that they administer on behalf of KDHE, we give them grant money for, which is federal dollars. So we get the federal money that comes to the state of Kansas. The local health departments then apply for that money. They have to give us a work plan that says how they're going to meet each of the deliverables that is required by the federal government. Then there is monitoring put into place. They are required to report to us on a regular basis on where they're at with the deliverables that they've said that they would meet. And they also are required to submit their affidavit of expenditure. So we are double checking that we're not reimbursing for something that really wasn't done and that we're reimbursing for things that are supposed to be done. And just a little snapshot of what your local health workforce looks like across the state. There's approximately 1,296 full-time employees and 100 health departments. Those 100 health departments do serve all 105 counties. We do have 2 regional health departments in our state. The average number of employees at each local health department is 13. So 13 people administering to an entire county. The smallest health department has 1 employee. and the largest health department has 145. More than 70% of the health departments reported less than 10%, or I'm sorry, 10 employees, and more than 41% reported less than 5. And then, as you might know, since COVID, local health departments have been experiencing significant loss in employees due to various things, such as threats to their lives, things like that that happened during COVID. There's been about a 50% turnover at the local level since COVID. Next slide. Going back to our agency, which a lot of these cannot be accomplished without our partners. So we were reaccredited. At the end of this last year, we found out we were accredited. We were accredited for the first time 8 years ago. And then we have to apply for reaccreditation every 3 years. We are accredited by the Public Health Accreditation Board. In order to maintain this accreditation, we are required on an annual basis to submit significant information to show that we're working not only with the legislature, but with the government, with partners across the state, both at the local level, at the state level, among other things. In addition to improving our work on a daily basis, we submit to them, and this all plays into our accreditation. Then they do an accreditation review with us, which happened in September, October. At that time, they can reopen anything they want of that you've sent. They had 2 questions for us, so I give all the credit to our team, who did an amazing job at gathering all the required documentation and ensuring that we were tracking along the way. So we received our reaccreditation status at the end of November with no findings. Another accomplishment that we have seen is the misuse of antibiotics. That's not an accomplishment, but we're recognizing that and working with our providers across the state on what is leading to antibiotic resistance and ineffectiveness, and we are able to share that data with providers and be able to do echoes or what have you with them for education. Our Kansas Home Visiting Universal Home Program is located in the Family Health Bureau that I mentioned earlier. They did see an increase of 31% of families that were served by our home visiting program over the last year. As many of you are aware, child care licensing remains a hot topic. Our agency was able to revise and update and amend 43 regulations in a very short amount of time and get them out of our agency and into law by this summer. It was a lot of work, but we did work with a lot of the partners ahead of time. We kind of did it backwards. We had all of our partners at the table when we were reviewing all these regulations, providers, parents, centers, whoever had an interest in childcare and the regulations, they were at the table with us so that we were able to write these in a way that would appease them and that still kept our children safe. Also, some of you are aware, we have and still have mobilized staff and resources addressing an unprecedented tuberculosis outbreak in one of our counties. We are working collaboratively with CDC on that. CDC remains on the ground with us to support. That's not a negative. This is normal. When there's something, an unprecedented or a large outbreak of any kind, they will come and lend resources to us to help get a stop to that. We are trending in the right direction right now. More to come on that. Hopefully we can get it wound down quickly. And finally, as I told you, the lab is getting ready to open. Thank you to the Legislative Building Committee and administration for allowing that to happen. Finally, next slide, goals. Obviously, one of our biggest ones is to get this TB outbreak to an end. I'll let Janet talk more, but we were awarded the Transforming Maternal Health Award from CMS. It's a 10-year grant that we will work with Medicaid on. Super excited about that. And then our legislative initiatives, some of you are familiar with these from years past. Update the newborn screening cap to allow for program growth. Some of you may be aware there's usually a proviso that's put in our budget to allow for that. Increase the state formula funding. So this is just lining up the language in the statute for local public health. You have increased the funding for them, their base funding, but we need it to be in the statute so that we don't have to continue with a proviso on that as well. And finally, there is a new energy source that has voiced interest in coming, and it's nuclear fusion systems. And so we'd like to at least get regulations and fees set in place so if they do make it to Kansas, we aren't coming to you trying to rush something through to get a fee structure set up for them, as we already have a fee structure in place for all of our nuclear energy. And with that, I'll turn it back over to Secretary Stanek unless you have questions.
Committee, I'm going to open it up for questions now. Senator Petty.
Thank you, Madam Chair. And Ashley, thanks for being here. You mentioned that the local health departments vary on how they get their funding. Is there predominantly a model? Is it through their local county commission that there's a funding source that comes directly from them, or is there kind of, this is what usually occurs, but there's other sources that come to?
Excuse me, Randy, if you called, may be able to talk more on this, but coming from a local health department previously, it was however the commission decided to fund their local county agencies. So if they wanted to give a percentage of tax revenue over to the counties, the health department, the agencies, county agencies, they could do that. If they had just an initial bucket of money, because we have so many, bucket of money that was just for public health, they can do that too. But there are certain requirements as far as like the tax is required, but then the other is based off what they want. Now, county commission also have to sign off on any funding that we are giving them. So if a health department applies for grants, actually right now, Aid to Local is what we call it. It is currently open. It'll stay open through March. And the health departments choose which of these they're going to apply for. The county commission does have to sign off on that, acknowledging that the health department is asking for these funds. This is a work that's required of them, and they're signing acknowledging that this will be done. In regard to that, health departments can apply. There is no set model on what grant programs they can apply for. It's generally recurring. Like usually they all apply for what they've been applying for. They don't all apply for the same things because of staffing and things like that. Does that answer your question?
It does. I just have a follow-up. So if, like you just said, Aid to Locals, if a local health department doesn't have the capacity to provide a certain service, then can a entity within that county, does KDHE then work with an entity within that county to provide that service?
If there's an interest. So, and it really kind of depends what it is. So like we have one county right now, for example, the maternal child health program, the health department had walked away from a couple years ago because they didn't have the capacity any longer to administer it. And so there was another partner in the county that saw the need, and they picked it up and applied for the funding with us. Now it's getting ready to flip back the other way, and the health department is going to reapply because that entity has said they don't have the bandwidth, but the health department has to be able to get the staffing they need. So yes, if there's interest in the county and there's an identified partner, absolutely. If we see by data or need that not having a health department administer a certain service, we will look for partners as we have several partners in all the counties based off the work that we're already doing. And if we think there's a good fit, we would consider talking with them and seeing if they were interested.
And are you working on these pieces of legislation for those, for the, like the newborn screening cap? Okay.
Yes.
Other questions, committee, before we move on? Yes, Senator Thomas.
Thomas, same thing. It's okay. I'm just curious about the CARES registry, because I don't know how closely you work with them, but like we talked about cardiac emergency responses last year in schools. We know, I don't know if there's data there that shows how many are occurring if they're registered, or how the CARES registry can help. And I don't know if this is a question for you or for someone else. I'm just curious about that and what can be done or what the status is.
So I think there's actually a hearing coming up on that to brief you on that. And that is in my division in one of my other bureaus. I did not bring that data with me. We can easily get it for you though.
No problem. Thank you, Madam Chair.
I just have two quick questions. You talked about the TB issues. Do we know where that started, and have we seen any other cases?
We do know where it started. We've been working on this since last summer. When we became involved with the health department, we were sitting at 65 active cases. So active tuberculosis means that they can transmit tuberculosis. And just so that you have an understanding, generally, if an active person takes 10 consecutive days of meds, then they have to have 3 sputum tests. A lot of times they will be then non-transmissible. Not always, so please don't have in your head always. So when that happens, then then they're no longer contagious. They can go about their lives. They don't have to stay away from people. And they can go back to work, do the things, as long as they continue to take their meds. So we had 65 of those when we first started working with the health department. In addition to those 65 actives, which for reference, we now have that down, I want to say, to 32 actives. So the difference in those two numbers mean they have completed treatment. But then on top of that, we have latent TB going on at the same time. Latent TB is what they call sleeping TB, which means they've been exposed. They will test positive to a skin test or a TB skin test, but they are not currently symptomatic. So they can't pass TB to anyone because they're not symptomatic. We determine that, obviously asking questions, but then doing a chest x-ray as well to make sure everything looks clear. If they're latent and they have not been treated, then the next course would be to put them on a medical regimen, then that keeps that latent TB from converting over to active. We started off with about as many latent TBs as we did active, and we've seen that number now decline as well because people have completed their meds. That course of treatment is several months. Both of them are several months. There's also, of course, caveats to everything. If they have underlying health conditions, things like that, that can complicate things, that changes the course. I will tell you, we still have a couple of fairly large employers that are involved that we're working with on this. And so we do expect to find more, but we're hoping the more that we find is latent TB, not active, so that their lives are not disrupted and having to stay home from work, because it is highly contagious. It is a respiratory virus. Currently, Kansas has the largest outbreak that they've ever had in history.
Thank you. Committee will move ahead now. Thank you so much. To our next speaker.
Me again. Sorry, Janet Stanek, Secretary. I'm going to cover, I'm going to start on slide 17, DHCF. Again, that's Medicaid. Christine is ill today. So the Medicaid program, we operate both the Medicaid proper and the Children's Health Insurance Program known as CHIP. We comply with federal rules, promote healthy outcomes for people enrolled in Medicaid, and we do optimize the federal dollars that come our way. And I'll talk a little bit more about that in a minute. Medicaid, again, is overseen jointly by KDHE and KDADS, but KDHE, per the federal government's requirement, is known as the single state Medicaid agency, so we have overall accountability and responsibility for the program. So KDADS, you probably are aware, oversees the Home and Community-Based Services, HCBS, waivers, behavioral health, and long-term care, and we oversee all the other populations, and we are also responsible for all the managed care organizations, those insurance companies that we contract with, that they remain in compliance with federal regulations to manage the populations under their enrollment. Medicaid is in CHIP, our partnerships between the state and federal government. We design our own program, but the federal government has to approve anything that we do. They give us some flexibility, but even if the legislature passes something, we have to get their approval 9 times out of 10. CMS, Center for Medicaid and Medicare Services, oversees the program as programmatic policy changes and funding. And the federal government pays roughly 62% of our Medicaid medical costs, 70% of CHIP's medical costs, and between 50 and 90% of all the other costs that's associated personnel, contracted services, information technology, and all that goes along supporting that insurance company that we run. So some key statistics as of October of 24 were that, and this moves a little because depending on where we were with COVID and enrollment and whatever, but 440,812 were enrolled. That's 360 plus in Medicaid, 60,000 plus in CHIP, and then 15,845 in the maternal and child health integrated program, which is called MCHIP. On page 20, we go over who's eligible. There are varying criteria determine whether you're eligible for Medicaid, but everyone that meets eligibility rules has a right to enroll in Medicaid. States cannot cap their requirements. They must be in a covered group. Those groups include children, caretaker, pregnant, disabled, or elderly. They have to meet technical requirements such as residency, citizenship, et cetera. And then there are financial requirements, and those all vary by, too much to give you in this overview, depending on where you fall in those groups. So we process all the eligibility applications for Medicaid and CHIP, and Department of Children and Family, DCF, you know them as, processes all of the other public assistance programs, such as what's known as TANF, Temporary Assistance for Needy Families, and SNAP, which is the Supplemental Nutrition Assistance Program. There are a number of services covered by Medicaid. Some of those are mandatory. We have to cover them, and other are optional. So mandatory include those that other states also cover if they receive federal matching dollars. Optional benefits that states choose to cover are if after receiving federal dollars. So we might do a waiver or something. Children enrolled in Medicaid are eligible for all medically necessary treatment and what's known as EPSTD, and you'll hear a lot about that in Bethel and elsewhere because it's a big hot topic. We have to do more to promote early periodic screening, diagnosis, and treatment, especially for our disabled communities. So some examples of the mandatory services would be what you get at the doctor, you know, an x-ray, a lab, outpatient treatment, physician services, et cetera. An optional service might be certain prescribed drugs, certain services such as hospice, podiatry, and DME or durable medical equipment, such as wheelchairs, bathing tools, et cetera. We are a managed care state. We have been since 2013. So we are in the round, when you hear KanCare 3.0, that's because we're in the middle of our, starting our third version of a managed care contract under being this. And roughly 90%, 5% of Medicaid is enrolled in managed care, known as KanCare. And the rest, basically we provide benefits through those MCOs. And right now there's Healthy Blue, there's Sunflower, and there's United Healthcare. Some non-KanCare or not managed care, which means they are fee-for-service or get paid as they go, would be Medicaid, or Medican, PACE, and there's a tuberculosis program, not related to what Ashley talked about, but it ties in. And they are paid, you know, per click versus a one fee where it's managed. And I already talked about on 22 who our managed care organizations are. Some major projects for Kansas Medicaid into 24 were really high focus on prenatal care and maternal child health outcomes. We did get what's known, you'll hear a lot about this, it's a TMAH grant, TMAH, Transforming Maternal Health. And basically, this is a 10-year, $17 million grant. We were one of 15 states that got this. We're very fortunate. We have a lot of our stakeholder groups you're going to hear from that are very excited because this remains something that we all have a vested interest with, improving those maternal and child outcomes. We did implement the contracts. We went through hundreds of changes are in place from the 2.0 to 3.0. And we are focused on member outcomes, provider experience, so we can get more providers to take our Medicaid patients. We have deserts where they are not, and we are working on that very hard. And we also have enhanced monitoring. Not only do we want to do, but we are required by the federal government. There's a new regulation that went into place that forces us to demonstrate we are monitoring the managed care organizations and how they are managing our patients. We were awarded a school-based services grant to expand services in schools to Medicaid children. I want to thank David Jordan from the United Health Ministries Fund because he helped us get that grant along with some others. We completed the first rate study we've done in 6 years, and we've also created a data and analytics bureau related to the rates. Just I'll put a little note in. Everybody wants a rate increased. It was very chaotic. We are trying to get a rhythm, a formula, criteria, et cetera, where we will do rates on a more fair basis, I guess, for lack of a better word, and use data to support why we're making a change versus someone coming in talking the loudest about why they need rate change. And that's not uncommon in other states. That's how it works. So I'm very proud of the team for doing that. So some of our goals in 25, fully implement these contracts that just started January 1st. So far, so good. initiate all of the work that goes into the year one of that TMA grant, which is basically that 10-year grant I just talked about, which lays the foundation. And then complete phase 2 and 3 of the rate study. We've completed phase 1. Phase 2 is to understand the relationship between the current fee schedule that's in place and the managed care organization payment to providers, because sometimes they're at odds. Phase 3 is to compare the complex pay structures, such as like the hospital rates are under what's known as a DRG system, a diagnostic-related group, and cost payments, and compare them to other like Medicaid states or regional. Complete research and recommend a revised graduate medical education program for Kansas. That's going to be a multi-year endeavor. It's in statute. It's very complex. And you will hear that is why I'm bringing that up. We have people on a team working on this right now. More to come, but moving GME and how we issue that so we can get more slots, more funding for medical schools and behavioral health and whatever is more complex than I can go into here. And then we had a lot of feedback before we implemented the MCO contracts, the new contracts from our stakeholders. People want to see the data in the Medicaid program. They want to see anytime they can log in and see where things stand with how outcomes, visits, providers, et cetera. So we are working on a public-facing dashboard on the performance of our managed care organizations and other key Medicaid data that wasn't previously available, not even through Bethel. Like that, we are trying to take the data that we have and do something with it that's meaningful and display it so we can make more informed decisions, and you all can help us make those informed decisions. So with that, I'm going to stop there and hope that wasn't too abbreviated, but we'll all take questions, and if we can't answer, we'll take them back. Thank you.
Great. And I just want to mention, committee, for those of you that don't know, the Bethel Committee to which the Secretary is referring, I chair that committee, so it looks like we'll probably have the end of January. By statute, we're required to have our next committee in January. So as soon as those appointments have been made for that committee, that will be on our schedule, so tentatively January 30th. Or is it the 30th or the 31st? 31st.
Oh, okay.
Okay, just to let you know.
Thank you for that.
To give you a heads up. And this is when we dive deeper into some of the information that she's talking about. So even if you're not in the committee, I would recommend that you listen in to Bob Bethel. Committee, any questions for the Secretary over this? Yes, Senator Blasey.
Thank you, Madam Chair, and thank you, Madam Secretary, for being here and giving that presentation. You talked about Medicaid rates and stuff like that. You know, last year the legislature did put a lot of work and effort into trying to increase Medicaid rates in many different spectrums. But specifically over the interim, when we were not in session, I had some concerns raised about how it was being allocated. And I'm just curious, did your department allocate as the legislature appropriated in terms of, like, for example, all physician codes were supposed to be a 9% increase? Were all codes given 9% increase?
There was, there's a couple different things with the physicians. No, not all physicians' codes were given the 9% increase. We landed on increasing rates up to 60%, and there's the whole formula on that I can show you. That currently is sitting with the federal government to approve, just so you know. We're fingers crossed with the administration transitioning and the timing of that. But many rates did go up, but not every single one, because there were some that were above. I mean, there was a lot of actuarial work to go in, who was way above already, who was below, et cetera. So I can get you more detail on what was approved, and I think Christine, back to the committee, she would have a detailed report on that.
That'd be great. If you're able to help break it down for me
Yes.
for every
Yep.
code,
Well,
so
we can have that be a
we know
follow-up
exactly where it all went.
Yes.
I thought the legislature just appropriated a blanket 9% increase across all
There
codes.
was something like that, but then there was some changes that went on, and I don't want to speak out of turn, but there was some things that it wasn't as clean as saying everybody gets 9%.
So when you say you guys are looking at all the codes and trying to make it fair, what do you mean by that? I mean, are there stakeholders at the table? Do we have providers?
Oh, yeah, I mean, like Kansas Hospital Association, for example. I think what I'm saying is that there might be people that were getting paid way over the rate, and some that haven't been looked at in beyond 6 years, okay? Like when I say we're doing the first rate study, that doesn't mean the rate hasn't been touched. And so to look, to see, use actuaries to kind of pull, of course, frequent use codes versus high impact codes versus low impact codes. I mean, there's a whole different way to look at this. And again, my term's fairness, it's like, where do you start versus, is it just, it felt like we shouldn't be basing our decisions on rate increases based on that short window of legislative session when people come in and say, we need our rates up, increased, you know what I mean? And we should have some science behind and some facts behind why we're increasing the rates. We are committed to doing this. We've hired somebody, like, we have a whole army of people now, and we should have been doing it. We should do it. There's some models, Indiana has some models in place, for example, that we kind of copied, and they have it in statute that they have to be increased. But we have a really good hold on it, and I'd be glad to get some detailed information and get that question answered more specifically, okay?
Thank you. And Madam Chair, is that something that the Joint Committee looks at specifically, or is there legislative stakeholders?
Yeah, Bethel does, yes.
Thank you.
We will look at that, but that's part of accountability of the committee, but I would also like to see that for this committee. Thank you.
In October's Bethel, which is online, and you can look, Christine did a high-level presentation there on where we were with the rates as well, just FYI.
Very good question. Thank you. Senator Holscher.
Yes, thank you. You talked a little bit about the $17 million grant, and we have talked about improving mental health, or maternal health and infant health here. Can you give us a little bit of a glimpse into what's going to be addressed with that grant?
I think from soup to nuts prenatal to, you know, I think that's a big thing, right? So there is like a fact sheet that's very easy to kind of, it summarizes it. And so what I'd like to do is, if you don't mind, get that to the committee. I have that, and I'll just remind me to follow up. And this will involve the Midwife Association and anybody else that take OBGYNs, pediatric. It'll involve a lot of different stakeholders. So I'd like to get that, and I'm sorry I'm not prepared to outline it for you today.
Okay, that's fine, thank you.
Senator Erickson.
Thank you, Madam Chair. Thank you, Madam Secretary.
thanks.
Appreciate it. Quick question. Was there a continuous eligibility waiver that extended Medicaid benefits to otherwise ineligible adults for 12 months?
I don't remember that specifically. There was continuous eligibility during the public health emergency. Is that the same one you're talking about where that ended in April?
No, it's my understanding there's been one extended just recently for 12 months. I believe it's an 1115 waiver. Are you familiar with that?
No, but I can get that. I can get you that. I'm not sure if that's on the KDAD side. I'm not sure. I will look. It might be for children. The children is ringing a bell for the CHIP program, so let me look, okay?
Okay, this is for adults.
This is adults? Okay,
specifically.
I'm not
Yes, ma'am.
familiar then. Okay, we'll follow up.
Thank you. Thank you, Madam Chair.
Thank you, Madam Secretary. We do need to move along to our
thank you.
next presentation. Thank you so much. Next, we have an overview of the Kansas Association of Local Health Departments by Randy Bowman. Randy, thanks for being here.
Thank you, Madam Chair, members of the committee. Randy Bowman, I'm the Executive Director of the Kansas Association of Local Health Departments, otherwise referred to as CALD. And this is my second year in this responsibility and able to appear before the committee and get to meet those of you who are new. I'll pause for the young gentleman here. Slide 2. So just real quick, you'll see the mission for CALD there, and we are, as Ashley did say earlier, we are the association that represents all 100 health departments, serving all 105 counties. There are 2 multi-county health departments in the state of Kansas. Slide 3. I want to begin just a little bit today with let's ground ourselves, if we can, in what really is public health. And there are many definitions out there if you go online and start Googling for them, but this one is pretty simple, in my mind at least. But it's what society does to collectively assure the conditions for people to be healthy. That's a lot when we think about what it takes to be healthy and what we can do to contribute, and I'll touch on that a little bit more. Then who is involved in public health? Because it is so large. This next graphic on slide 4 does an attempt to kind of tie all the pieces together that are connected to public health. There are some who aren't on here you could definitely make a case for, but we're talking about nonprofit organizations, civic organizations, hospitals, drug treatment providers, corrections, you as elected officials and your elected peers at the federal and the local level as well, transportation, fire, all is interconnected. Slide 5. And that's important because really we need to think about what we're investing in, what we are prioritizing in our attempts to impact the health of all of our folks, because there are things we can make investments in that really help us save long-term costs. And I think that's something we all are invested in, is saving costs in our own family budgets, in our own businesses, in local government, in state government, and federal government as well. And if we do those preventative measures and look at things like investing in vaccine, nutrition education, clean water infrastructure so that we have clean water to drink, we can make an impact. By doing that, we can help our economy and our workforce. If folks are not sick, they can come to work. They miss less work. They're more productive in the workplace. Healthier people also pay less out of pocket for their insurance premiums, as you probably experience yourself and hear from your constituents. Yeah, you may have insurance coverage, but the out-of-pocket costs can be thousands, if not tens of thousands of dollars per year on individuals. Our communities, do they look nice? Are they clean? Are they attractive? That attracts people to live there. That attracts businesses to come there. That helps the economy grow and grow the tax base, being desirable places to live. Next slide, please. So this illustration, whoops, sorry, I got ahead of you. I'm already back up to the little person. Thank you. So a whole lot goes into that. Socioeconomic factors. What level of education do we have? What's our job status? Do we have support from our family and loved ones or from friends or others in the community? All factor into making us healthy, and that actually is the largest part of what helps us be healthy. In physical environments, where you live, where you work, what type of setting. If you're in a manufacturing setting, what kind of chemicals and things are you exposed to, as many people are? Then the old lifestyle choices. We all go see our physicians, I hope, as a preventative care, and some of us may get the lecture occasionally, lose a little weight, do a little less of that, a little more of this. But those are about 30% of what drives our health and ultimately drives the cost of health care, which is really only about 20% of the whole. So if we work on that top 80% and be more proactive and work on those things going forward, we can have less dependency on the very, very expensive and very, very necessary. When you're injured or ill, you need that health care, but it's just a smaller portion than some may sometimes think about. I'm gonna take a little different approach. I actually covered some of this, so I'll hit this light, but some of the examples in public health, I'm just gonna go back in history here than current public health things going on. I think that's important to realize, because what we're doing today and where we live today, we just have not lived what our great-grandparents, other ancestors lived. We haven't lived the outbreaks that are, because we have safe water now, we have safe food, we have clean air, we've invested in traffic safety across time, we've had anti-smoking campaigns for most of our lifetimes at least. Those have been in place since about the 1950s. Collectively, you go back a century and a half or so, 1860, the average American lived to be 39. Average American lived to be 39. In 2010, and it's been pretty stable since, a little moving around, it's 78, so roughly double. That's public health in action. That is our workforce. If you die at 39, you're not going to be at the workforce, but if you live longer, stay in the workforce, you can contribute more to society. But there are things we need to be working on, and I would say for CALD, we as memberships, we are here to be a resource to you. Look forward to working with you as you look at public health through the lens of what should we be doing next. Chronic disease is a problem in the United States. We have obesity, cancer rates, heart disease, stroke. That's what kills us in this modern day and age. How can we work on those things? How can we start making investments and set policies to make that better? Mental health crisis, a lot of conversation about that. A lot of you have made some major contributions as legislators to that in the last few years, but we need to be working on that and our environment. Extreme weather events, -12 is what my truck said driving in here this morning. 14 inches of snow that we had in Topeka a few weeks ago that set a record in the city of Topeka. But other things like, okay, air pollution, that contributes to asthma and other ailments that mean you're consuming healthcare resources. You're spending money, whether you're privately insured or publicly insured. That is money that could be avoided if we clean up our air, is another example, or continue to clean up our air from what it has been in the past. So with that as a framework, decentralized public health system after local health departments, sorry. As Ashley talked about, we are decentralized, but I'll hit a couple things of what that means. That means your health departments are employing county employees to do the work. That's 100% in Kansas. You'll have other states where it's kind of hybrid. The big cities will sometimes be state-run or city-run or vice versa. And the other part, sorry, I messed that up. Big city might be county or city-run, and the small will be state or vice versa in some other states, and some other states are state-run. But what that means is all county employees, the health officer, the leader of the administrative leader of the organization is hired by the county, not the state. The county has no say in their hiring. The local government can do taxing, which I'll come to next, to help fund that. And that the majority of the funding is local level instead of the state level is some of that definition. Local flight. So locally, health departments, as Ashley had on there, you saw the size of them. They are very, very small, except for in Wichita and Wyandotte, Johnson, Shawnee County, those. That's Kansas. We're all familiar with that. But it means there's not much resource out there. It means there's not a lot of services that many of them can provide when you're talking about a 1 or a 3 or a 7-person health department. It doesn't mean the small number of people there don't have tremendous amounts of needs, though. Don't have the scale of needs, but they have the same scope of needs as anybody living in our metropolitan areas. So local public health through local health departments, this is not always going to be the health department doing the program, as was talked about before committee a little bit earlier. It will be working with stakeholders, and other stakeholders are going to apply for the grant. Others are going to have the bandwidth to do the grant because maybe the health department doesn't currently. So we work across as many organizations as we can with that. State level, Ashley talked about this too. It's really, there is some aid to local, and that funding stream that they're working on statutorily, we do support to move that baseline from $7,000 to $12,000. How much can you do with $12,000 in an organization in this day and age? Not much. That's really the most flexible pool of fund that health departments have to address local needs. Everything else is going to come through grants, whereas it was talked about earlier. The grant criteria are going to require you to do this and that. So does that match your community's need? You might apply. If it doesn't match your current need or you don't have the bandwidth, you may not apply. So that gets kind of a patchwork of systems. Those grant requirements and terms and conditions and scope are all defining what can be delivered in some communities as well, and those are coming from the state and federal government. Lastly, how much of that money, and looking at 2025 survey, about 39% of the gross revenue for health departments comes from that local taxing ability that the county commission has, 40%. About 43% then comes from the state and feds through various streams that may or may not meet needs at a period of time and always have a certain terms of use and condition, which is appropriate, but it does narrow what you can do in local government. And that splits about 21% state and about 22% federal. About 14% comes from reimbursement. Health departments are able to reimburse through Medicaid, Medicare, private insurance, those types of sources as well. And then 4% comes from some other sources. Occasionally they'll get a grant from a foundation or donation, those types of things. I'll wrap lastly, what you do at the local or the state level has a tremendous impact on the local level. You're not a budget committee, but I want you to know that there is something called the Laboratory Courier Services. It's about $1.2 million a year. KDHE has worked with you all for the past couple of years. Other funds have been able to cover that instead of state general funds, but those other funds are basically being exhausted, to my understanding. Keeping that going is critical to your local health departments. Beautiful, shiny new lab just 2 blocks from us here. How do the other 104 counties access it if there's not a laboratory courier to bring those samples here for water and biological samples? So that, if you were to not find a way to fund that, means it's going to come out of that local funding, which means less services are going to happen for your communities at the local level if they have to cover the laboratory courier service. So with that, I'll stand for any questions, Madam Chair.
Randy, thank you so much for being here. In committee, we are out of time, so I'm afraid if they have any questions, that's okay. If they have any questions, they can reach out to you directly. Committee, we are dismissed.